Hi, everyone. Hope you all are doing well and you're enjoying this snow experience safely. We're going to continue to talk about the central and peripheral nervous system, of course. And in this particular lecture, if I can get there, of course, there you go. In this particular lecture, we are going to talk about upper motor neurons, lower motor neurons. We'll talk about cranial nerves, and when we speak or talk about these specific kind of parts of the central and peripheral nervous system, we will also talk a little bit about how damage to these areas, how it would manifest essentially. And then we'll talk about neuroplasticity and its application to rehab and rehabilitation. Now, the upper and lower motor neurons, as I alluded to in the previous slide, they are part of the central and peripheral nervous system. The upper motor neurons are located, or they start off from the cerebral cortex and the brainstem, and they ascend down through the pathway and through the internal capsules to the spinal cord, where they connect with the lower motor neurons. And the lower motor neurons, of course, continue with that pathway through the spinal cord and to the musculoskeletal system to which that they attach. The purpose of this particular network is to transmit information from the cortical area, the primary motor cortex, down to the spinal cord to the particular muscle groups that are innervated. And this information that comes from the command center, the cerebral cortex, and the brainstem to the musculoskeletal system essentially leads to voluntary movement to occur. So this pathway is very essential for any type of voluntary movement of the limbs and again the musculoskeletal system. The book, the Lundy-Ekman book, categorizes the upper motor neurons into 4 different categories. There's the medial upper motor neuron, there's the lateral cortical spinal tract, non-specific upper motor neurons, and the cortical brainstem tract. A lot of the tracts, though, that descend down from the primary motor cortex to the lower motor neurons are in the lateral cortical spinal tract. There's also another categorization of these descending motor pathways. And this categorization is the pyramidal tract and the extrapyramidal tract. One thing important to note is that this pathway from the cerebral cortex, from the brainstem to the spinal cord and to the lower motor neurons is called an efferent pathway. There is another pathway that comes from the peripheral, the musculoskeletal system and other parts of the body back up to the brain, and that pathway is primarily responsible for transmitting sensory information to the brain for processing, and that's the afferent pathway. In this lecture, we're primarily talking about the efferent pathway. Now, there are multiple upper motor neurons, or pathways, descending pathways, I should say, or tracts. The lateral cortical spinal tract is one of the tracts that I mentioned earlier in previous slides. This tract essentially sends information for essentially voluntary movement to the muscles of the limbs, the hands, and the feet. The anterior cortical spinal tract, that's primarily responsible for transmitting information to the axial skeleton, such as the trunk. The cortical bulbar transmits information to the skeletal muscles of the head and the neck, and particularly through the cranial nerves. The rubrospinal, similar to the lateral cortical spinal, sends information to the muscles of the limbs, the hands, and the feet. And the tectospinal primarily does so for the head and the eyes in response to visual stimuli. Now, let's take a look at a few of these tracts, and let's kind of examine to see what their descending pathway looks like. When we look at the lateral cortical spinal tract, right, it originates from the primary motor cortex, it descends down through that internal capsule. Then when it reaches the medulla oblongata, that's when it crosses over to the other side. So for instance, the pathway that comes from the left side, essentially when it comes to the at the medulla oblongata, then it crosses over to the left and it continues its travel. Similarly, from the right side, it comes down until it reaches the medulla, then crosses over to the left and continues its travel as well until it reaches the anterior horn, where then it attaches or synapses with the lower motor neuron. The anterior cortical spinal tract, it follows the same kind of travel pattern, but it crosses over at the spinal cord, not at the medulla oblongata. When it crosses over at the spinal cord, it is at that point where it also connects with the lower motor neuron. The rubrospinal kind of follows a similar pathway as the lateral cortical spinal, but that crossover happens before it reaches the medulla oblongata, not at the medulla oblongata. So as you can see that each pathway has, or each kind of motor neuron or tract has a slightly different pathway to where they need to get. All right, so what is this? Earlier we talked about where the upper motor neurons, many of them originate, right? They originate from the primary motor cortex or the cortical area of the brain, and that's where the gray matter is. And we understand that the gray matter is where the cell bodies are located, and as the axons descend, it becomes the white matter, and because of the kind of the fatty tissues that are associated with the axons. Now, this is a picture of the primary motor cortex, and essentially you can assume this, or you can understand this as the command center. This is where information comes from, for the most part, in association with other regions of the brain, of course. Now, the reason why we see this picture on this primary motor cortex is because the different parts of this cortex is designated for sending information to a specific part of the body for voluntary movement to occur. Body parts that are responsible for finer movements have larger representation in this cortical area than body parts that are more responsible for grosser movements. For instance, there are a lot of finer movements that often occur at the lips and at the face, and also at the hand, right? The hand is responsible for a lot of fine motor control, as we know, or movement patterns that are required for manipulation and things like that. And because of the degree of fine movement that is often present and required by the hand and the face, larger area of the primary motor cortex is dedicated towards sending those type of information to those body parts. Whereas the shoulder, the trunk, the hip, the knee, they're involved in gross movement patterns. And so they have limited or smaller representation in this cortical area. Now that we understand, there's a command center, upper motor neurons originate from, this command center, the cortical area and the brainstem, and they descend through the internal capsule to the spinal cord, where they attach to lower motor neurons at different levels, or different areas, I should say. And these lower motor neurons then continue through that pathway to the musculoskeletal system, which they innervate. And we understand that this pathway is, the primary responsibility of this pathway is to allow the control area of the brain to send information down this pathway to the musculoskeletal system for voluntary movement to take place. Now, damage or lesion to these two different parts of the nervous system could occur. and could lead to different type of symptom presentations. And we'll look at that in future slides. For upper motor neuron, these lesions occur at the brain and spinal cord, and that is primarily because that's where the upper motor neurons are located for the most part. Well, yeah. And then, of course, damage or lesion to the lower motor neurons, they typically occur or they impact these fibers that are traveling from the anterior horn of the spinal cord or from the cranial nerves, which also could have neuromotor neurons. Yeah, so that's where these lesions would take place. Damage or lesion to the upper motor neurons could occur because of a stroke, MS, traumatic brain injury, cerebral palsy, Parkinsonism, multiple systems atrophy. It's kind of like a neurological condition that kind of has a similar presentation as a Parkinson's, but is a little bit more debilitating and has a lot of kind of blood pressure issues associated with it as well, and atrophy. And ALS. Now, it's important to understand that ALS, very devastating disease, does impact both the upper motor neuron and the lower motor neurons. And so it has a kind of a widespread kind of impact. And from a lower motor neuron standpoint, any peripheral nerve injury that can be caused by trauma affect the lower motor neurons. Great Guillain-Barré, polio, quad equina, ALS, as I said earlier, all these are conditions that affect the lower motor neurons. All right, now, when we talk about injury or axonal injury to the peripheral nervous system, which also includes the lower motor neurons, these injuries could occur due to any type of trauma, from sharp objects, extreme stretch, motorcycle accidents, motor vehicle accident, anything that really affects any impact of trauma that affects the peripheral nervous system certainly does lead to these injuries. Post-injury of the axons in the peripheral nervous system, sometimes there could be a growth of a new branch of an intact axon, or there could be a regrowth of the damaged axon that could take place. These regrowth of the damaged axon is called, or a new branch formation of an intact axon is called sprouting, and we'll come into that in future slides. And this process can essentially take a long time. And sometimes when there is axonal sprouting that occurs, that leads to inappropriate target innervation that could lead to problems such as pain and things of that nature. Damage to the central nervous system, again, similar mechanisms can cause that as well. An injury can cause that, a motor vehicle accident impacting the spinal cord or the brain. Those type of injuries can affect the central nervous system and can lead to damage of the axons or the neurons, essentially. Now, in this scenario, axonal tearing could occur, or just damage to the axon. Axonal death can occur as well. Now, in this case, axonal regeneration within the central nervous system doesn't quite occur. So if the axon is dead, it's essentially dead. And we'll come when we talk about neuroplasticity, we'll discuss about what kind of changes that occur that lead to recovery outside of axonal regeneration. So why is it important for us to know these things? Why is it important for us to understand the upper motor neurons, the mechanism by which that they transmit information from the brain to the musculoskeletal system, and why is it important for us to know that damage to a specific area, whether it be upper or lower motor neurons, could lead to certain type of symptom experiences. Well, as we kind of repeatedly talk about, we treat the person or the human, and certainly not the diagnosis. In increasing our awareness of how these systems work and what symptoms could be present when there is a disruption of that system through injuries or such, it allows us to anticipate when we see these diagnoses what impairments could be present. And in kind of that anticipation, it could allow us to also have a general understanding of what functional capacities may be impacted, and what assessment tools that we need to select to administer at initial evaluation, and what to look for at initial evaluation. The more robust our initial evaluation is, the better plan of care we're able to establish at the get-go. That would allow us to select appropriate interventions. And also the knowledge of how these systems work and these structures work, and how damage to these areas, would manifest from a symptom experience standpoint, would allow us to predict functional outcomes as well, which essentially guides our intervention selection and intervention approaches. All right, now let's take a look at some symptom experiences for lesions in these specific areas. When it comes to upper motor neuron lesions or damages, we could expect muscle weakness to occur, motor control deficits, hemiparesis or complete paralysis. We could expect increased flexion, sensory deficits. These are the kind of things that we can experience or expect with damages to these areas. And at times, with the upper motor neuron lesion, nerve conduction tests may not necessarily be abnormal. When it comes to lower motor neurons, we can also expect paresis and paralysis. We also would expect muscle atrophy. Significant atrophy could be present. In the case of reflex, we would expect hypo versus hyper. Sensory deficit can be present, paresthesia, pins and needles, and things of that nature. And in many cases, when there's damage to lower motor neurons, there is an abnormal conduction with the EMG testing. All right, let's transition into interventions. This is not going to be an all-encompassing intervention slide, but because we identify or we recognize that changes to tone can occur with injuries to the upper motor neurons, more particularly hypertonicity, which is increased tone, or spasticity, which is abnormal muscular activity that is not voluntary and evident with high velocity movement. Because they do tend to occur, there needs to be a proper management of these hypertonicities or spasticities. If not properly cared for, it could lead to pain, it could lead to joint tightness and loss of range of motion. One of the major interventions for hypertonicity is pharmacological, oral medications. There are various types of oral medications. And Botox injections that oftentimes occur every 3 months or so. Hyaluronidase is another injection that is not FDA approved at this time, but used in a lot of research. From a non-pharmacological approach standpoint, the therapeutic approach, right? Passive range of motion training, prolonged passive stretch, whether it be through splinting or casting, dynamic or static splinting, manual therapy, thermal modalities like heat, particularly pre-stretch, could be helpful. Right. Now, interventions related to motor recovery, neuromuscular re-education is a principle that is utilized a lot within the rehabilitation arena. Encompasses mass practice, motor learning principles, utilization of electrical stimulation, weight bearing, CIMT, constraint-induced movement therapy, which is a therapy protocol where the stronger extremity is immobilized where the person is forced to use the weaker arm for activities for an extended period of time. The person would have to have a certain amount of movement available for them in the extremity in order for them to be appropriate for this treatment modality. Hopefully, in the future, we'll have more time to discuss in depth about these different treatment approaches. Of course, we address occupations, right? We address functional engagement. So in talking about functional engagement, there's a compensatory strategies that we oftentimes apply. Having techniques, introduction of different type of adaptive equipment and things of that nature. All right, now we're going to quickly transition into cranial nerves. Cranial nerves, they supply motor innervation to the muscles of the face, the eyes, the tongue, the jaw, the neck muscles. They transmit somatosensory information from the skin of the muscle and the muscles of the face, I should say, and the TMJ. They also transmit sensory information related to visual, auditory, vestibular, taste, smell, and all of that. And they do provide parasympathetic regulation. What that means is that they can help regulate heart rate, blood pressure, breathing, digestion, pupil size, and things of that nature. So there's a lot of utility to these nerves. There are 12 nerves within our nervous system, and each would either have a sensory responsibility, a motor responsibility, or a combination of both. What you see in this slide is the mnemonics that are often used to memorize the cranial nerves and their roles and responsibilities. Now, where are they located? Cranial nerve 1 in the inferior lobe of the brain and inferior frontal lobe of the brain. Cranial number 2 in the central part of the brain. Cranial nerves 3 to 12 follow a 2-4-3 pattern. 2 of them, 3 and 4, are located in the midbrain. 5 and 8 are located in the pons, and then 9, 10, 12, the last 3 are located in the medulla. All right, why do we need to know these things? Same thing, right? Understanding what they do and understanding injury to those specific cranial nerves would allow us to determine what impairments to expect, and would allow us to also pick proper intervention and assessment strategies and tools, and that would allow us to pick appropriate treatment strategies, and it would also allow us to essentially prognosticate outcomes. All of that because of the understanding, I should say, that we treat the person. Now, let's take a look at a couple of cranial nerves and what they do and what injury to those nerves may look like, or what symptoms they may present. Cranial nerve palsy, first of all, I should say, before we go into those specific nerves, what does a cranial nerve injury present as? It may cause partial or complete paralysis of the specific area that the nerve innervates, right? And these injuries can be congenital, they can be traumatic, they can be due to blood vessel issues or other systemic issues, such as infections, migraine, and tumors, and things like that. Some injuries may resolve over time, and others may be permanent injuries. All right. Now, cranial nerve 6. It is responsible for lateral eye movement. Injury to this particular nerve would essentially affect what we call the abduction of the eye that is affected. So if it is a left cranial nerve palsy, right, the left eye may have difficulty moving towards the left side, that abduction. Now, people with cranial nerve 6 injuries or palsy may experience double vision because, again, those eyes are not symmetrical and they're not moving symmetrically. And so the brain will interpret visual information as 2, more particularly when the person is looking towards the affected side, because the right eye is going to move towards that direction, and the left eye, however, the left eye is not going to. And so that kind of creates that perception of double vision. Bell's palsy, cranial nerve 7, It is something that most of us are familiar with. It leads to partial facial paralysis, drooping of the face on the side that is affected. All right, so these are just two of the many cranial nerve injuries. And if you look at your book, chapter 20, it explains different types of cranial nerve palsies and what symptoms to experience. All right, so we've looked at some, the different kind of parts of the central nervous system and how they work and what injuries in those nervous systems, what symptoms it would present. Now, from a rehabilitation standpoint, neuroplasticity is a principle that is key. What neuroplasticity is the ability of neurons to change their function, their chemical profile, essentially the amount of neurotransmitters produced, or their structure. Sometimes new neuronal connections may form, axons may sprout, and then the sprouting of these axons essentially may allow them to be sensitive to neurotransmitters around them. This neuroplasticity could be experience dependent, and it oftentimes is experience dependent, and we'll come into that in future slides. And oftentimes it does involve new learning occurring. The three types of neuroplasticity mentioned in your book is the habituation, I should say, experience-dependent plasticity, and cellular recovery after injury. We'll look at them in more detail in future, starting with this slide. Habituation is a process by which that there is a decrease in response to a repeated stimuli. For instance, I'll give an example. A person goes into a multisensory environment. Person gets overwhelmed because of all the sensory stimulation. That person then stays in that environment for 15-20 minutes, and they become to adapt to that environment, and they're no longer as overwhelmed as they were. So their system has learned to adapt to that particular environment. So in that case, that short-term habituation has taken place. Now, assume that person leaves that environment and comes back the following day, and they experience that sense of overwhelm again. And that is because the habituation that took place is a short-term habituation or desensitization. However, with repeated exposure to similar settings, the person no longer then, when they enter into that type of environment, they no longer feel that sense of feeling overwhelmed. In that scenario, long-term habituation has taken place. Habituation is a principle that is oftentimes used in therapy, PT and OT, for addressing sensory profile processing disorders like tactile defensiveness, vestibular impairments such as dizziness caused by different type of movement patterns, and concussion. And really the principle here is that you gradually expose the person to these symptom-provoking activities and then kind of have them remove themselves and come back. And with those processes, they establish that desensitization. Experience-dependent plasticity, that's this is a process by which that a long-term or long-lasting neuronal changes occur from a neural network standpoint, and it leads to long-term motor learning. The example that could better explain this is, let's say that a person who first learns to play the piano. And at that moment, when they first learn to play the piano, it requires a lot of cognitive output, and larger areas, the activation of larger areas of the brain is needed for them to perform the task. As they get better, less and less cognitive output is required, and less part of their brain is required for them to perform that task. So that long-term motor learning is occurring. From a cellular recovery standpoint, as it relates to neuroplasticity, and this refers to synaptic changes that occur following an injury, some cortical reorganization that occur. By that, what we mean by that is that different parts of the brain can start to take on the role of the area of the brain that has been damaged to the best of their ability, essentially. Um, and and then, as I mentioned earlier, the axonal sprouting is something that occur. The axonal sensitivity, where they become more sensitive to neurotransmitters. Those are the different kind of cellular recovery patterns post-injury. All right. Neurogenesis is another potential mechanism by which that neuroplasticity can occur. Although in the central nervous system, we understand that once an axon dies, it dies. It doesn't. There's no neurogenesis that typically occurs. All right. So rehabilitation and neuroplasticity. Neuroplasticity is very important in rehabilitation, as we've talked about earlier, and early intervention is critical for recovery post like stroke and traumatic brain injury and things like that. There is a sensitive period for the potential more recovery post injury is optimal or the best, essentially. And this is the first days to the weeks and months post injury, as of course the injury becomes more chronic. Although neuroplasticity does still occur, it may not occur as robustly as at the early stages of the recovery process. However, it's also important to understand that aggressive therapy early on may also have a negative effect. Ideally, therapy, the ideal kind of therapy start time period would be no less than 24 hours post-injury. Also, we don't want to delay therapy, right? So anything after 24 hours certainly would be the optimal time to start therapy. And then, of course, although intensity does matter, and intensity is greatly associated with most optimal recovery, I should say. High intensity, vigorous therapy early on, it could lead to a negative consequence, essentially. All right, so specific types of rehabilitation that are effective post-stroke. Task-oriented or task-specific training there's a lot of evidence for its efficacy. And what that essentially means is that picking tasks that are salient for the person and having the person perform those tasks with the affected extremity with high repetition versus simply doing exercise-based interventions. Task-specific training is shown to induce more regular patterns of brain activation compared to just simple exercises. So task-specific training, there's a lot of evidence. And then there's also a lot of evidence about high-intensity therapy and its outcome. Additional evidence-based interventions, electrical stimulation, neuromuscular re-education, virtual reality systems, technology, splinting, bracing, those are also evidence-based interventions that are essential and of course can yield positive outcome with, of course, task-specific being the superior of those. All right, this is it for this lecture. If you have any specific questions related to any of these topics discussed, feel free to reach out to us at any time. We're more than happy to clarify anything. Have a wonderful day.